Good evening, everyone. Thank you so much for joining us. We are just going to give everyone a few moments to log on, and we'll begin shortly. As we're giving everyone a chance to log on, I do want to remind everyone that a recording of this will be sent out within the next couple of days, and we encourage you to submit your questions in the Q&A section, and we'll do our best to get to as many of them as possible. And it is my great pleasure to welcome all of you to In the Middle, Managing Your Midlife, Things to Know About Menopause. And I would like to hand things off to Dr. Loeb.
Thank you so much. Welcome, everyone. So glad you're joining us for this really important topic. So October is Menopause Awareness Month, and today happens to be World Menopause Day. And the theme for this year's Awareness Month is menopausal mood and cognition. Sleep is such an important component of our mood and cognition, and many menopausal women report difficulty with sleep. So I am delighted to welcome Dr. Daniel Barone this evening to share his expertise. Dr. Barone is the Associate Medical Director of the Weill Cornell Center for Sleep Medicine. He specializes in the evaluation and management of patients with all forms of sleep disorders, including sleep apnea, restless leg syndrome, insomnia, and narcolepsy. He is certified by the American Board of Psychiatry and Neurology in both neurology and sleep medicine. He's well published on the topic of sleep medicine. He has a book and a YouTube channel entitled Let's Talk About Sleep, and I know we will learn a lot from him. A third of US adults report that they usually get less than the recommended amount of sleep. That increases with menopause and perimenopause when at least 40 to 50% of women report some difficulty with sleep. Not getting enough sleep is linked with many chronic diseases and conditions such as type 2 diabetes, heart disease, obesity, depression, and cognitive changes. It can lead to motor vehicle accidents and mistakes at work. The good news is that there are treatments and behavior modifications that can significantly help with sleep disorders. So let's get started talking about the basics of sleep and sleep disorders. So let's start, am I right?
Yes, Dr. Loeb, you are right. And thank you for having me and for that wonderful introduction. Sleep and sleep disorders, if you look at the medical literature in the last probably 50 years, the amount of publications and interest has gone up exponentially. And the reason for that is because we know as doctors and clinicians and even scientists that when you don't get enough quality or quantity of sleep, that can have consequences, both immediate in terms of how you feel and how you function, but also long-term, right? In terms of all the things we mentioned, increased risk of diabetes and heart disease and so on and so forth. And the menopausal population is a special population because a lot of them do have sleep disorders, which, you know, I'm sure you know.
Right. So is it right you want to get between 7 and 9 hours of sleep a night?
Well, the National Sleep Foundation put that recommendation out a few years ago. The average person needs 7 to 9 hours. Now, it's a bell curve, and there are some people who need far less, and there are some people who need far more. I would say the thing to watch out for, especially as we talk about menopause, is if a woman has been, let's say, an 8-hour sleeper her entire life, right, and has felt fine, no problems, and then goes through menopause, now she's only getting 5 or 6, that's a problem. But
Mm.
if somebody has been a 5 to 6 hour person their whole life, that may be just who they are.
That's interesting because that's a question that came up from a participant. Is it okay if I only get 5 hours of sleep at night? Right. All right. So there are lots of different reasons why people can't sleep, right? Insomnia is probably the most common. Is that correct?
Well, insomnia, that's a pretty broad term. So insomnia is defined as difficulty falling asleep or difficulty staying asleep, or even sleep that has chronic unrefreshing, is chronically unrefreshing. So one of the biggest causes of insomnia can be something like sleep apnea, which is a condition where people stop breathing throughout the night. So it kind of gets murky in terms of, what causes the difficulty with sleep. But the biggest question is it problem falling asleep or problem staying asleep?
So what are causes of trouble falling asleep and staying asleep?
Well, robocalls. I would say that the biggest trouble with falling asleep really ties to one of two things. One could be anxiety, right? When people have trouble falling, shutting off their brain, and that can be, people outside of menopause too, right? Anybody can have trouble falling asleep, especially in Manhattan, right? Stress, things in the brain, right? That can make it hard to fall asleep. Physically, what can happen is if women have hot flashes, or if there's something called restless leg syndrome, where people have uncomfortable legs that prevents them from falling asleep. Those are amongst the big reasons why people have trouble falling asleep. When we talk about maintaining sleep, that can be a variety of things. The things we just mentioned, right? Depression is classic for early morning awakening. Menopause itself, the hot flashes, the temperature changes, that can wake somebody up. The need to urinate, okay? And sleep apnea, which is, as I said, a condition where people essentially stop breathing throughout the night.
So I'm just back from a menopause conference, and my understanding of both anxiety and hot flashes as it relates to sleep is that it's sort of bi-directional, right? So you can have anxiety and then wake up, or you can wake up and then you have anxiety, and the same is true with hot flashes and night sweats.
Exactly right. So you want to think of it this way: is if you have, again, poor quality or poor quantity of sleep, that puts your body into kind of an inflamed state or a proactive state, and that can lead to trouble with dealing with anxiety the next day, or trouble with dealing with stress, or trouble dealing with hot flashes. Basically, it's like your body is primed to have problems when you don't sleep well, and vice versa.
Yeah, and we're going to get to some of the treatments for some of the things we just discussed in a little bit. But another thing I learned at this conference, actually, it's not just getting the right number of hours of sleep, but it's also the proper timing of sleep that's really critical. So if you're going to bed at 2 a.m, that's also not good for your natural circadian rhythm, right?
That's right. And one of the good examples I use, it's funny, actually, I gave a talk to the internal medicine residents today in the morning. And what I told them was, if you're working overnight, you remember this from residency too, right? When you're working overnight, it's like, you're up all night and you think you'd be exhausted the next morning to present to your attendings. But what happens is, it's like, yeah, you have a jolt of adrenaline, sure. But it's also, this morning time when the sun is out, this is your brain telling you this is the time to be awake. Okay. And then when you finally are done with that and you go home to try to sleep, your brain is telling you it's time to be awake still, and it's hard to fall asleep. Well, the sleep you do get, if you work overnight, is not great quality the next day. And that's because of circadian rhythm.
You can't judge sleep by a resident, because that's just the most altered sleep of anybody, right? I used to be able to sleep with a room well lit with people walking in and out and a TV blasting. So that's no example, right? But going to bed too late, it really can both affect your mood and your cognition, right?
That's right. Yep. You have to have your brain has a window that it wants to sleep in, and that's part of good health, good sleep health.
Right. My alma mater, Brandeis University, they won a Nobel Prize for studying the circadian rhythm and how that really impacts your your health, your overall health, right?
Right.
Yeah. So you started talking about this, but let's talk about like how this does affect our bodies, not just sleep well. Like, why is it so important to get sleep?
Right. Well, think of it this way. I mean, if we think about things in health in terms of evolutionary terms, right? It's like the whole idea of sleep, it's putting you in this very vulnerable state for 8 hours or whatever it is at a time, right? So if you think back to evolutionary times, right, or primitive times, our ancestors would be at risk for predation, right, for sleeping, for like the way we do now. So there must be something so important happening with sleep, otherwise evolution would have weeded out of the need for humans to get sleep, right? So we have to think of it in terms of that way. It's not something we can just kind of put off and say, oh, I'll sleep more tomorrow, I'll sleep more on the weekend. Sleep affects us in really our every organ system, especially the brain and the heart are affected by a lack of quality sleep. And like I said, I mean, what happens is the body is repairing itself. It's storing our memories. It's kind of getting rid of things we don't need. It's getting rid of toxins. And when that process does not happen regularly for years, the consequences can be essentially life-threatening.
Yeah, and what I read says that even one night of fragmented sleep can have an impact on your mood. Like, it's not very much.
Yeah, I mean, it's that in that case, I don't want to get people too worked up over this, you know,
Right.
because that can lead to its own problems too,
Sure.
right? But one night is not a big deal, and you can quote make up for that. But it's just when these problems become chronic into years and decades, that's when we have an issue.
Yeah, and we talked about a little bit why menopausal women wake up. It could be that they have to run to the bathroom or they're having a hot flash. Let's talk a little bit why apnea seems to get worse around the menopause too.
Sure. So what happens is if you look at the how often sleep apnea is diagnosed in women are actually protected against sleep apnea, and then around the time of menopause, that curve really steepens and it almost reaches that of men. Okay, so across the board, you're looking at 24% of men, 9% of women have sleep apnea. Again, stoppages of breathing throughout the night. What happens, though, is actually women are protected against this until menopause occurs. And as you know, and obviously, you know, menopause, what happens is estrogen and progesterone are no longer basically there. Progesterone has many effects in the human body. One of those is a respiratory stimulant, okay? Estrogen has many effects, including fat distribution. Okay, and one of the things that happens when estrogen and progesterone are no longer there, you can have kind of a layer of fat microscopically. We're not grossly, but microscopically inside the airway, and that plus the lack of deep breathing, let's call it, that combination can take somebody who had a predisposition for sleep apnea and make it real. So I have seen this 1,000 times where a woman will come to me. She's 59 years old. She never snored her whole life. She was a great sleeper her whole life. Now she's done with menopause, and she says, you know, my bed partner says I'm waking up snoring. I'm gasping throughout the night. My weight has remained the same. I look exactly the same as I did, but it's because she went through menopause, and that problem, which was potential, has become real.
So when should a woman come for an evaluation for sleep apnea?
Well, I mean, this goes for anybody. I say if somebody has chronically disrupted sleep or sleep that's not refreshing or trouble even falling asleep chronically, I would say it's good to get evaluation.
Yeah.
Yeah.
Absolutely.
Hmm.
So menopausal women are so busy. And so for us, sleep is so important. My girlfriends and I call our menopausal age the silly putty generation, because we're getting not sandwiched, but we're getting pulled in so many different directions.
Yes.
So for not sleeping, everything we do gets more difficult, which is why this is such an important topic.
That's right. Yep.
So let's talk about what we can do. So first, when should someone see you? When should we seek care from a specialist?
Well, like I said, I think a lot of these things, you know, as we're going to be going over, I mean, you know, there are checklists you can do and say, okay, you know, maybe I'll have my 8 glasses of water per day, but an hour or two before bedtime, I'll cut it off, right? I'll do good sleep habits, which we all know, right? Not watching TV before bed, not using my phone in the middle of the night. I'll cover my clock, so I'll make sure that I'm not looking at the clock throughout the night. I'll try to meditate, right? These are all things you can do to kind of put yourself into that mode of relaxation enough to get to sleep and to stay asleep.
I think we should reiterate what you said, right? The screens before bed, the relaxation techniques before bed, right?
I'm a big believer in things like meditation, mindfulness meditation. You know, there's a lot of good apps like the Headspace and the Calm app. Those are great. You know, get into the habit of exercising in the morning and meditating at night. Trying to avoid sleeping on your back, because on your back, that's really when gravity will pull your tongue backwards, and that may cause sleep apnea to occur. So if you're doing all those things and you're still having trouble, that's when I would say you want to come see someone.
There are probably that I've read about other good habits we can practice, right?
Oh yeah, there's many. Yeah, there's many in which you can,
kind of using your bed mostly for sleep, right? And not
right.
staying in longer than the hours that you're sleeping.
So
Go
yeah.
ahead. Go ahead.
What I usually say, and this is kind of like I'm being cute when I say this, but what I say is, you want to look at your bed and your bedroom almost as a sacred place, right? And you don't want to do anything in that sacred place that may desecrate that, temple or whatever it is, right? So what that means is you're only using your bed for sleep and intimacy. That's it. If you're not doing either one of those things, you're not in bed. And that includes lying there, ruminating and thinking about things. Because what happens is down the line, your brain gets conditioned. It kind of gets like, it starts to think, this bed is not my place of sleep. This is my place of where I worry or where I stress out or where I go through the day. And that, like I said, can have consequences down the road of making your brain be like almost conditioned that, all right, I'm in bed, not going to sleep.
Yeah. So good advice is to go to bed when you're really sleepy.
That's right.
Not to read a book, but do that somewhere else, right?
And in some cases, actually, what we do is we actually have people kind of shorten their time in bed. That's part of what we call cognitive behavioral therapy for insomnia. So we actually shorten the time that they spend in bed to eventually tire them out, right? Not in a punitive way, but to tire them out. So that way down the road, their brain starts to understand, okay, this time and this bed, this is my place of sleep. And if I'm tiring myself out, eventually what it does, the brain recognizes, okay, this is the time I'm going to fall asleep easier. I'm going to stay asleep. And then we extend it from there.
That's really interesting. And one more behavioral thing I understand is trying to go to bed and wake up at the same time.
Right.
Yeah.
Right. So that's a big thing. So I would say probably one of the biggest, problems I see is that people will be sleep deprived during the week and then on weekends try to make up for it. And it is very pleasurable to kind of sleep in on a Saturday. And we all know that, right? But what happens is that's your brain telling you need more sleep. Okay, you definitely need more sleep. It's better to be consistent the weekdays into the weekends, not just timing, but also the amount, right? So that way you're not, I would say more than an hour in on the weekends, more than an hour extra is probably you are chronically sleep deprived. So you want to.
That is true, but that's true for many of us, right?
Exactly.
Yeah. Right.
Well, what happens is, sleep is the kind of the easiest thing to kind of say, all right, I'm going to put that off for tomorrow, or I'm going to worry about that on the weekend, or I'm going to blah, 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 and it becomes an issue where it's like, all right, you just keep doing that. Eventually your body is going to say, no, you can't do that anymore.
Mm-hmm. Another thing I read is don't stay in bed unless you're asleep. Right. But so go ahead. What were you going to say?
No, that goes what I was saying before. It's like, if you're lying in bed, just thinking there or just lying there, your brain has to know this bed is my place of sleep. And when you're doing anything in there other than sleeping, obviously if you're there for 15 minutes and then you fall asleep, it's no problem. But if it's there for hours and hours and hours, your brain starts to think this bed is not my place of sleep. This is my place of something else.
So help us. So many women wrote in the questions beforehand. What do I do to get back to sleep when I wake up to go to the bathroom, or when I wake up with a hot flash? How do I get back to sleep?
Well, I would say that probably the best thing to do is kind of the same principles of sleep hygiene apply to the middle of the night. So what I mean by that is, you don't wake up and check your phone. You don't wake up and watch TV. You don't wake up and go on a screen. Maybe you sit at the edge of the bed and do some meditation, right? Get your mind relaxed, get back to sleep. If you want to try to reduce the amount of time you're going to the bathroom, cut off the water intake before bed, like I said. Mm-hmm. But again, if this is a chronic problem, you may want to get some help by myself or one of my colleagues. Usually what I do in a case like that, where somebody is chronically waking up in the middle of the night, I always ask the question, why? Why is this happening? And sure, it can be hormonal stuff, and you can hormone replacement therapy. You can have a discussion with Dr. Loeb or her colleagues. But if we're going to look at just sleep related things, one of the things I'd be looking at is, could this be sleep apnea? Mm-hmm. If that's the case, we take care of that, right? And there's ways we can talk about that. If that has been ruled out, let's say, but somebody is still waking up in the middle of the night, that's where things like maybe natural medications or natural substances can be helpful. I am partial to melatonin. If somebody hasn't tried that yet, okay, it's natural, it's over the counter, it's something our brain naturally makes. The brand that I like is called REM Fresh. That's REM Fresh. And what that is, it's time release melatonin. So if somebody has trouble staying asleep, let's say, what I would do is have them take maybe 2 milligrams of REM Fresh before bed. And, it's not a miracle, but it may help them to get to sleep a little bit easier. And then we can, assuming that everything else has been ruled out.
My understanding, melatonin is best to help you get to sleep, but it's not as good for sleep maintenance. Is that right?
That's not true.
That's not correct. Okay.
No, so which is why I'm partial to this brand, because it's time release. Okay. So if you're just taking immediate release melatonin, what can happen is, it can help you to fall asleep. Or I have some patients do is they'll take it in the middle of the night to help them get back to sleep. But you always run the risk of doing that is, waking up groggy the next day.
And what's your thought about drinking wine with dinner or late night eating, how that impacts sleep also?
Yeah, I mean, wine is interesting because, any kind of alcohol, really, it doesn't matter if it's wine or anything else. Alcohol in the system can actually help us to fall asleep. That actually can happen. And believe it or not, even the first hour of sleep can actually be pretty good. But what happens is once the body starts to metabolize the alcohol out, it's almost like a mini withdrawal occurs. And people, as we wake up in the middle of the night, they wake up, have to go to the bathroom. It's not really a good aid to use. So if somebody is having a glass of wine with dinner, let's say at 6, and they go to bed at 11, no problem. But when we have that nightcap and closer to bedtime, that's where alcohol really can disrupt your sleep. On top of that, if somebody has sleep apnea, the alcohol can make it worse.
Late night eating, does that affect it too?
Yeah, late night eating, I don't want people to go to bed starving. I also don't want them to go to bed with a very full stomach. Okay, so if somebody is very, very hungry before bed, what I recommend is maybe some protein, like a little peanut butter or so. That can be useful to kind of get them through the night. But when you have a big meal close to bedtime, you run the risk of reflux.
Right.
Okay, and that's a big thing, which I think people don't talk about enough. Is reflux can wake people up coughing. They can wake up choking throughout the night. It's not sleep apnea, but it can be related to that.
Yeah, absolutely. And so some tricks for that are elevating your bed, not eating so late. Right. Absolutely.
Right.
All right. So you touched on this briefly, and I want to just delve into a little bit more because one of the first line treatments for sleep disorders is cognitive behavior therapy for insomnia, right? So can you talk, that's interesting. And can you talk about the principles of that?
Sure. So cognitive behavioral therapy is kind of a combination of techniques that a psychologist would use. I mean, we sometimes use them too as MDs, but there are specialists out there, behavioral specialists who do this work. And basically what it is, there's really 3 main components to it. One is something called sleep restriction, which I kind of alluded to a little bit earlier, which is, it sounds like a misnomer, right? But if somebody is, let's say, lying in bed from 8 p.m. to 8 a.m., right? They're in bed for 12 hours, but because of insomnia, they're only getting, let's say, maybe about 5 or 6 hours of sleep. As we just discussed, that's actually not a good thing, okay? Because the brain starts to get rewired. Okay, this bed is not my place of sleep. So what we do there is what we call sleep restriction, where we cut out some time in the front end and we cut out some time in the back end. So let's say Miss Jones is getting into bed at 8 p.m., leaving at 8 a.m. What I'll say is, all right, I actually want you to delay your bedtime, not even touch it, until let's say 12 or 1. And then I want you out of bed, no matter what, by let's say 6 or 7. Okay. And initially, when somebody hears that, they say, how's this going to help me? This is a nightmare. I'm already not sleeping as it is. But what you're doing is you're cutting down the time that they have to sleep, and they're not allowed to nap, right? So you're cutting down the time they have to sleep. And what happens is after about a week or 2 of this, it's not fun, but after about a week or 2 of this, what starts to occur is the brain starts to get rewired. Okay, so this window of time that I have, this is the only time I get to sleep. So what happens is the body's natural propensity to want to sleep starts to take over, and they start to fall asleep easier, and they start to stay asleep a little bit longer. And once that process is happening regularly, then we open up the window a little bit. Maybe instead of 6 hours, we give them 6 hours and 15 minutes. Okay, and we kind of reverse it that way when we get them back to their 7 or 8 hours, kind of a restructuring kind of the way their brain views sleep.
So you're training someone that bed is for sleep, right?
Right, exactly. So that's one component. That's probably the strongest component, if you will. The second is called stimulus control therapy. And what that is basically, again, we've alluded to this already, it's only using the bed for sleep and intimacy. That's it. So what that means is if you get into bed, let's say, and 15, 20 minutes has passed, just estimating, not looking at a clock, right? Just estimating. If that time has passed, you would not lie in bed. You would get up out of bed. This would go both for initially sleep, and then if you wake up in the middle of the night, you get out of bed, go to the kitchen or the bathroom or not living room, whatever. And what you would do is you would do some relaxation technique, read a book on paper or meditate or listen to soft music, no screens. Okay. And then once you start feeling sleepy again or tired again, you can get back into bed and try again. Okay. And you keep doing that as many times as it takes. Again, the whole process here is to train your brain that this bed is my place of sleep and nothing else. So if you use those two things together, that's what cognitive behavioral therapy is. That does work very, very well. The third part of this is relaxation techniques. So, I'm a big believer in meditation, massage therapy, acupuncture, anything like that. I'm all for.
Deep breathing, does that help?
Deep breathing, same thing. Yep.
Yeah. So you said with the second type of cognitive behavior therapy, you just don't, it becomes so agitating to lay in bed and not be able to fall asleep. So you don't let yourself get to that place.
Yep.
You get up before you get yourself all worked up,
That's
do
right.
something else and come back.
That's right. Yeah, that's called stimulus control therapy.
Yeah, I mean, these things sound so doable in real, that if you're struggling, it's something worth trying.
And what I always tell people is like, even if it sounds not doable, even if it sounds too tough, like I've had patients say, I can't get my TV out of my bedroom. That's just something I have to have. It's like, well, just let's make little changes. Let's make little changes at first and kind of, build up to the bigger thing. So maybe instead of, okay, I'm not going to force you to take the TV out of the bedroom, but maybe shut it off.
Yeah.
I mean, it sounds trite, but that kind of stuff can help.
Make sure you use the sleep timer if you have to keep it on, right?
Exactly,
yeah, for sure. Yeah, I'm a big believer in mindfulness too. I think it really does help.
Yeah.
It helps women going through the menopause transition for sure.
Right.
Other supplements other than melatonin, that was a question that came up.
Yeah, I mean, there are other things out there. A lot of this stuff is, Susan, a lot of this stuff is not extensively evaluated with, randomized controlled trials and stuff. So a lot of this is case reports here and there and just overall clinical gestalt. So things like valerian can help, magnesium can help, chamomile. You want to make sure that your doctor knows you're taking these things in addition to whatever else you may be on, because while they themselves may not be dangerous, they may interact with some of the medications you're on. So
100%, such an important point to make sure your provider knows all the medications and supplements you take, because there are interactions, and most of the things you mentioned are benign, but not always. So we're worth mentioning, right? Okay, so the FDA, we use some medications that are approved by the FDA and some that are off-label, and we start with the FDA-approved medications.
Yeah. Well, I mean, there's several out there. I honestly don't even look at it in those terms. I don't look at what's approved and what's not approved. It's kind of what I think is going to work for the person. I would say probably my number one medication prescribed across all medicines is probably trazodone, okay, which is an SARI. So that's a serotonin medication. It's a little bit different than SSRIs that everybody's heard of, the Zoloft and Paxils and medications like that. What trazodone does is it's a sleep aid, right? So it does help people to sleep, but because of the serotonin impact of it, it helps quiet the mind down, okay, which is very, very important when it comes to chronic insomnia. It's pretty benign. You can't use it, or you have to be careful using it when somebody is already on an SSRI, let's say, for example, so an antidepressant. You have to be cautious with combining them, but there are many patients who do fine with it. But the great thing about it is it's not addictive. So whether or not somebody responds to it, if they respond to it, great, but if they don't, there's not really any harm of addiction or any risk of that. So we can just kind of start it and stop it and use it as we need to. So that's my first line.
And that is effective in both lengthening sleep time and the sleep maintenance.
Right. Because, again, in the context of somebody who's having these problems, what one of the issues is, could they be just having trouble shutting off their brain? Obviously trazodone in a case of sleep apnea is not going to cure that, right? But if the person has sleep apnea and they have anxiety, right? So we put them on, let's say, trazodone or so, we take care of the sleep apnea, that really should solve the problem.
Yeah, because people can have more than one issue
Right,
going on
exactly,
for
exactly,
sure,
exactly.
right? And you don't feel drunk in the morning or overtired in the morning?
I mean, you know, that can happen with anything, right? Anything we've mentioned so far. I mean, anything that can help you to sleep potentially has the risk to carry over and leave you feeling tired. But if that's the case, you know, we just maybe back off the medicine or take it earlier. You know, there's ways around it. Yeah.
Sure. What other medications do you use? Gabapentin, the
So
ubiquitous
yeah,
medication for
right.
everything, right?
Everything, right? As neurologists, we use it for, it's like water. So I read somewhere it was the third most prescribed medication in the US, right? Yeah, that's my number two, actually. And the reason why gabapentin works is it's kind of a unique mechanism of action. It basically works on the system that quiets everything down, both physically and mentally. Again, not addictive, you know, despite what, you know, you may hear. And it's pretty safe. Honestly, it's a pretty safe medicine. It can attack a lot of different things. So it can be used for pain. It can be used for restless leg syndrome. It can use to, there's some data to show it can actually improve the depth of somebody's sleep. So again, assuming that bad things, quote unquote, have been ruled out, that's another option for us.
And in my line of work, it improves hot flashes. It's one of our
There you go. Right,
alternative
exactly.
treatment for menopause. It's for women who can't or won't take estrogen. It's an alternative treatment for
Perfect.
hot flashes and night
Perfect.
sweats. So
Yep.
in that way, it might also be helping sleep for
Perfect.
sure.
Yep. Definitely.
Doxepin.
Yeah, Doxepin I use every now and then. Again, that's more in the context of somebody who has, you know, because Doxepin is partially antidepressant, it's partially an antihistamine. So what I may use that for is if, again, somebody has trouble shutting off their brain. I'm not crazy about antihistamine medications, you know, which Doxepin is part of, you know, Benadryl, ZQuil, things of that nature, because it can affect memory down the road. So I try to avoid that if I can. I mean, Doxepin is definitely lesser of those evils as far as you know, risk of memory problems, but I think there are better things out there.
Yeah, that's interesting because we're trying to improve sleep to help our memory. So we don't necessarily want a drug that's going to impair that also, right?
Right.
So antidepressants, what's the role for that?
Yeah, I think a lot of that stuff, you know, the question of antidepressant is one of, you know, who's taking care of these people, right? How are these people getting taken care of? And I think a lot of times, you know, as you know, Susan, a lot of this is multimodal, right? So, you know, you're seeing you for menopause, you're seeing me for insomnia. They probably, you know, many patients probably should have an evaluation by a psychiatrist for depression and anxiety. You know, I mean, especially in New York, where there's so much hustle and bustle. So I am a big believer in kind of using a combined approach. So let's say a psychiatrist sees them, okay, let's put you on an antidepressant. I'll see them, we'll do a sleep test, maybe see what's going on. You know, you work with your aspect. That's kind of really where the person I think gets the most bang for the buck.
Yeah, you know, Paxil has an FDA-approved label for the treatment of menopausal hot flashes. So in doing so, that might also help sleep. And I have
sure, of course,
yeah, in women for sure.
I mean, yeah. So antidepressants, just to answer your question, they can help, right? So if anxiety or depression is a major problem, they certainly can help. But there is some literature actually that can disrupt sleep as well. So you know, we have to temper those problems against what else we're doing.
Yeah. So many of us don't write too often for sleeping pills anymore, the traditional Ambien
Good.
What's your feeling about that? And
yeah, I mean, Ambien, Lunesta, Sonata, you know, the benzos like Klonopin and Xanax, they have a role, they do, but I try to avoid them. If somebody has come to see me, you know, for a second or third opinion, chances are they're on one of these medications. And I try to tell them, look, I think there are better, safer things out there for us to try first, to maybe get you off these down the road, because again, they can affect memory, they can have some addiction properties, they can worsen sleep apnea, okay, because they relax the body. So, you know, if we try other things and nothing else works, which sometimes happens, then yeah, I mean, I have no problem keeping them on that, but I want to make sure we're not missing other things like sleep apnea, and we're not trying other better medications for them, but they do have a role.
And do you let women take them nightly or as needed, or?
Yeah, I mean, it kind of depends on the circumstance. I mean, the best is always less, But if they need it every night, then yeah, I mean, that's again, the caveat I said before still holds. But if
Sure.
they need it every night, they need it every night.
Yeah. So I'm going to take a moment to talk about hormone therapy. That's more in my line of work, right?
Yeah, definitely,
So,
definitely.
menopausal women, especially in the 2 years before that final menstrual period, going to at least a year afterwards, and sometimes for longer than that, up to 80% of women will complain about hot flashes and night sweats. And the best, most effective treatment for that is hormone therapy, estrogen and progesterone therapy and it's FDA approved for the indication of what we call vasomotor symptoms of menopause. We know that hormone therapy is safest. Not everybody can take it. There are certain contraindications. We did a whole webinar on this, so you can definitely refer back to that. But it's safest for the right candidate when used within the first 10 years of menopause up until age 60. And if you're suffering with hot flashes or night sweats, it might be very safe and highly effective to use that. And so that's a discussion to have with your physician. When I'll just briefly, when I was first in practice many years ago, everybody was on hormone therapy. And then came the Women's Health Initiative study in 2002, showing an increased risk, heart disease, stroke, maybe breast cancer. And so we pulled everybody off of it. But the pendulum has definitely shifted more in favor of it. And it's definitely effective. Can help mood, can help sleep, might even help cognition. So it's something, just putting that out there to discuss. I don't know if you have thoughts about that too.
That's great. No, I defer to you folks on that. I do get questions on it every now and then, so that's good to know that it is considered that way. But isn't that so interesting though, how things in medicine, they swing one way, then they swing back the other way. It's just that's just the way it is. And it probably drives patients nuts, because it's like, wait, all right, so I heard this years ago and now this is the case. So
it certainly is confusing, and it is, that's why we have this midlife program. We spend a lot of time discussing it. Women know the myths or know some facts about it, and it definitely is not for everybody. And that's why we do have alternatives that we've already spoken about, but it's definitely a conversation worth having.
Good. Yeah, sure. Good. That's great. That's great.
Yeah. I think you mentioned it when we talked about apnea, but there are treatments for that too. There are devices. Do you want to just briefly talk about how we treat sleep apnea?
Yeah. So what obstructive sleep apnea is basically, it's the tongue falling backwards over the course of a night, kind of closing off the airway, right? So if you look at it like this, let's say this is a normal airway when we're asleep. When it gets to this, that's where kind of the airway is tight, and that's where snoring happens, right? Which is just vibration of the tissue. And then when it closes off, that's what sleep apnea is. Now, the kind of classic example of that is somebody who's, choking and making all kinds of noise. But not everybody does, especially women. Women do not present necessarily that way. So if somebody is waking up multiple times throughout the night, even if they're not aware of making sounds, that is something you want to think about. That being said, what sleep apnea is a mechanical problem. So what we want to do is we want to treat it mechanically. And the kind of gold standard is what's called a CPAP machine. Probably everybody's heard of that before or seen it. Continuous positive airway pressure. Okay, the last P is very important. And it's a mask that people wear over the nose or in the nostrils, attached to a long tube, attached to a box, looks like a clock radio, okay? They put this on at nighttime, they press the button, and what this machine is going to do, it's going to blow pressurized air, not oxygen, not like, they're in the hospital or, just pressurized air. And that pressurized air is going to go all the way down to the back of the throat, and it's going to force the airway open. So anything like this, snoring, sleep apnea, it's all going to go away. Okay. I've seen it change people's lives. I mean, it's not for everybody, as you said about hormone replacement therapy, but in the right patient, it works like a charm. And I think it's probably one of the best things we have in the entire field of medicine. It's just air, right? There's no real downside.
Yeah.
That's option one. Not everybody can tolerate that, or, they don't want to have that for many understandable reasons. The next line down is what's known as a dental device. Okay, and what that is, it's kind of looks like a sports mouth guard. It gets made by dentists, and they mold it to the upper and lower teeth. When the person puts it in their mouth at nighttime, you see what I'm doing here? It gives them an underbite. And what that does, it takes the tongue away from the back of the throat, again, opening up that airspace. Okay, it doesn't work as good as a CPAP machine, but in the right patient, it can be curative. Okay. Then there are surgical options out there. Probably the most talked about one recently is the Inspire device, which is a lot of commercials for now. The guy is he's bouncing around with a remote control in his hands. I don't need a CPAP anymore, right? They don't explain what it is though. What it is, it's an implantable. It's like almost like a pacemaker that gets implanted into the right chest wall, and there's a wire that goes under the skin which clips onto the hypoglossal nerve, which is a nerve which controls the tongue. So after it's set and surgically implanted and calibrated, the person will turn it on with a remote control at nighttime. And basically what it does is it sends an impulse to keep the tongue stiff so it can't fall backwards and close off the airway. Does it sound like Twilight Zone? It does. Does it work? It does. But it's the right patient, just like everything else.
Yeah. Risks of that procedure?
Well, like any surgical risks, right? There's always the potential for harm anytime you do surgery. But really, no, it's not like, you have true hypoglossal nerves, so there's not really risk of like cutting it, but it's more the question of will it work or not, right? And it's always a challenge.
Yeah. So I see a question in the chat, which we haven't talked about, is THC or CBD.
Right. I get that all the time. That's a great question. My opinion on that is the following. I am not opposed to it, but we just don't know the long-term effects. Okay. And what I can tell you is that CBD, THC, any kind of marijuana product, what they do is they certainly can help with anxiety. They can help quiet the mind down. They can help induce sleep. But substances like that can actually inhibit the brain from getting REM sleep or REM sleep, okay, which is when we dream. Now, if you talk to somebody who chronically smokes marijuana, they'll tell you, if I smoke every day and then I stop, my dreams come back full force. I get nightmares. It's crazy, blah, blah, blah. That's because the REM sleep that they've been deprived of is trying to be made up for. So when you use these substances, just be aware that there's, we don't know the long-term consequences of not getting REM sleep, but we're getting reduced REM sleep. But what I would say is if it's a question of not sleeping at all or getting some sleep and reduced REM, I'd probably take the latter. But anybody who tells you we know all the facts and it's 100% safe is lying, or they don't know what they're talking about. So yeah.
I hear. I'm just looking through a few questions that have come up in the chat. We've addressed a lot of them. There's someone that asked if there are certain foods that we should avoid that can affect sleep. Obviously, caffeine is one.
Yes. Let me talk about that for a second. So caffeine is really interesting. We all have a cup of coffee. That's great. It gives us a boost of energy. But what caffeine can do in some people, it can have a half-life up to 5 hours. So what a half-life is basically how long the caffeine will stay in your system, right? So there are some people who metabolize caffeine very slowly. So if they have a cup of coffee, let's say 4 o'clock in the afternoon, they get that energy burst for 20 minutes and they think it's out of their system. When they try to go to bed at nighttime, the caffeine may still be there. And even if it's just a little bit, that can be enough to tell the brain, not time for sleep. And that can screw everything up. So what I usually tell people is with caffeine, you want to have your 1 to 2 cups or even 3 cups a day. That's fine. Maybe by 1 o'clock though, no more. Yeah. So that's one thing. The other thing is going back to this whole idea of reflux and GERD, right? As a possible reason to wake up. If you're somebody who's subject to that, you don't want to have a big, huge, spicy meal, especially around bedtime, because that will definitely cause problems.
I think that causes hot flashes too. Actually, I counsel my patients regarding that also.
Yeah.
And another really good question that came up a couple of times is, how about someone who works different shift hours, works night?
That's a problem. My official recommendation is to try to avoid that if you can, but of course that's a ridiculous thing to say for everybody. But what I would say is what happens when you're working shifts is you really have to try to make the sleep that you do get as high quality as you possibly can. So that means at times when you have a normal, let's say you can get to bed at 11, wake up at 7, you really want to make sure you're optimizing that as much as you can. When you come home from a shift, the best thing to do is wear sunglasses, okay, and try to avoid the sun, because what the sunlight does is tell you that you're supposed to be awake right now. So when you go home after a long shift, let's say it's the morning time and you're really tired, the sunlight's coming in, what that's telling your brain is to shut off melatonin and be ready for the day. And that's the opposite of what you want. So you want to cover your eyes, maybe even try a little bit of melatonin. Okay. But it's tough. There's no great answer for that, for working shifts. It's not a good thing.
Yeah. And the shifts are, it's
Long
not
term,
7
long
days a
term.
week. Yeah. And it's not 7 days a week. So it really gets
Right.
confusing,
Exactly.
right?
Exactly.
Yeah.
Right.
Yeah. So, I mean, there's some great questions here because this is such, again,
Yeah.
an important topic and such a difficult topic.
Sure.
It's disheartening
Yep.
for people when they can't sleep,
Yeah.
right?
Yeah. It encompasses a lot of potential fields, as we're discussing this. Yep.
Yeah, just like menopause, very
Right.
multidisciplinary,
Exactly.
right? Exactly.
Right.
Any kind of parting words of wisdom, closing remarks that you'd like to make, anything relevant to our menopausal patients that are on tonight?
Well, I think the bar should be pretty low. If you're having trouble and nothing that you're doing is working, you read this or that online, or you read my book. Let's talk about sleep. If you go to these sources and you're doing all the right things, quote unquote, and nothing is helping, I would say it's definitely worth getting an evaluation. Oh, okay. I think that there's no harm in talking to somebody who does this kind of work and just seeing if there's other things that can be done, because there are plenty of reasons why somebody may have trouble sleeping, and there's plenty of things that we can do about it.
Yeah. And I was going to say something similar, as a provider for many menopausal women, it is partly my responsibility to ask what symptoms, including sleep, you're experiencing, but it's something you should bring up, because there are many things that can be done in my office. And if I can't do it, then I send to Dr. Barone or one of his colleagues to help with. And it is so important for long-term health that it's worth addressing. Yeah.
Definitely.
Yeah. Well, thank you so much for sharing your expertise and your wisdom tonight. I think it was really informative and helpful. And if this will be recorded and shared with you for joining this evening. And thank you all for joining.
Thank you very much, Susan. I would say this: if there are as many more questions, I think maybe even a part 2 down the road might not be a bad idea, because there is still so much to talk about.
Love that idea. Thank you so much.
Sure. All right.
Bye.
Bye.